overall survival have increased from months to years actually, and patients are very happy. These drugs are relatively less toxic as compared to the chemotherapy what we normally give. So to be honest, yes, we can consider it as a eureka moment for the cancer patients, especially the ovarian cancer.
Due to its ambiguous presentation, sneaky nature, and recurrence risk, ovarian cancer ranks as the seventh frequent cancer in women and deadly gynecological malignancy globally. One of the significant factors that influences the development of ovarian cancers is genetics, that includes family history and BRCA gene abnormalities. The use of PARP inhibitor therapy is the most recent development in the treatment of high-grade serous ovarian adenocarcinomas. BRCA mutation tumors as well as homologous recombinant deficiency tumors are susceptible to base excision repair blockage by PARP inhibitors. The degree of effect of PARP inhibitor therapy can be determined by diagnostic assays that assesses HRD status from the tumor blocks out of ovarian cancer patients. In today's episode, we will understand about homologous recombinant deficiency from Dr. Amit Verma. Dr. Amit Verma is founder and director of Dr. AV Institute for Personalised Cancer Therapy and Research. He is a well-known medical oncologist and a cancer geneticist with over 15 years of experience. He believes in contemporary approach towards cancer, popularly known as Precision Oncology. To his academic credentials, he has done his MD from AIMS and fellowship in cancer medicine from MD Anderson Cancer Center from University of Texas. He's also been the initiator of Personalised Cancer Medicine Clinic and the first molecular oncology tumor board in India. Welcome, Dr. Amit Verma. So, Dr. Verma, a lot of new tests keep erupting in the market, and these days the new buzzword is HRD testing. Can you explain us about HRD?
Thanks, Payal, for that important question. HRD stands for Homologous Recombination Deficiency. So this test is basically pertaining to evaluate the HRD either score or the HRR gene alterations or impairment or HRR gene pathway defects. So these are the important aspects of a HRD test, which involves a lot of complex testing, which is either based on the tumor genomics, that is at the tumor DNA level, and sometimes there are functional aspects of it where they talk about some implications of these alterations into the cells. So these tests are meant for patients, especially to identify those patients who will be eligible for special drugs called PARP inhibitors. These are nothing but a form of a target therapies which helps these patients to respond better. And sometimes certain chemotherapies like platinums works like a charm for patients who have HRD defects.
Okay, so this is a new interesting test, but is this test universal for all cancer types?
Um, Again, a very interesting question. This concept is universal, but this test is not applicable for all the cancers. As of now, we are using these kind of tests for majorly four major types of diseases or the cancers. Primarily, it is the ovarian cancer. The second most important cancer where we use it more often is the prostate cancer. Third is breast cancer, and fourth is pancreatic cancer. So these patients, when they fail the conventional chemotherapy lines, we tend to go for these kind of tests to identify which patient is eligible for these special drugs. In certain scenarios, we try to use these drugs upfront, that is in maintenance setting, especially in ovarian cancer. These tests sometimes become very handy at those times. So primarily, four major cancers, I repeat again: ovary cancer, prostate cancer, breast cancer, and pancreatic cancer. These are the four major indications where this test is recommended.
All right, so Dr. Verma, you just said two things, that this therapy is advised when there is a failure in the couple of lines of chemotherapy, or when someone is suggested maintenance therapy. So what is the difference between these three types of therapies?
So the PARP inhibitors, which are the topic of discussion based on the HRD test, is basically used in two settings. One is the treatment setting, that is when you see a disease and you want to treat it. That is called treatment setting. Then there is a setting called maintenance setting. When there is no disease, you want to use these PARP inhibitor drugs in order to prevent the recurrence or delay the recurrence. There are two settings. In ovarian cancer, the guidelines talks about the use of these drugs at the time of failure, that is when you see progression of the disease after giving chemotherapies, after 2 lines or after 3 lines, depending upon the drug of choice, has been recommended. And in that case, you can use these drugs during the course when the disease has spread, you have evidence of disease, when the treatment like chemotherapy, especially platinums, are not working. Those kind of scenarios, you can use these PARP inhibitors. And the second scenario is maintenance, which I just talked to you about, where the treatment is given after the completion of the treatment, like we do the chemotherapies and surgeries, everything is taken care of, and then patient is disease free, and we want to prevent the recurrence.
Okay.
That is called maintenance setting. So two settings.
Is maintenance therapy for all cancer types again?
So I just said that this drug is used for in two settings, that is treatment and the maintenance, and primarily for indications. But as of now, the maintenance recommendation is limited to ovarian cancer. But for treatment purposes, all four indications is a norm actually. So depending upon the patient's stage, patient status, patient treatment history, and the patient current disease status, these drugs can be used.
So, if I understand it correctly, all ovarian cancer cases, once they're treated, can also be given this therapy as a maintenance therapy,
Yes.
whether or not the disease is there in them.
Yes. So depending upon the HRD status, the patient becomes eligible for these therapies, even if the disease is not there.
So, we circle back on HRD. May you be able to explain what is actually the significance of this test? And we've also heard about PARP therapy. So, HRD test, PARP therapy, I don't know where do they connect or meet.
Okay, so it's an interesting concept. The HRD and PARP inhibitor therapy is based on the concept what we call synthetic lethality. So synthetic lethality, you can understand that imagine if you have two important genes, gene A and B, when they are present, then it is not cytotoxic to the cell. When A is there and B is abnormal, still the cancer cells are not undergoing any kind of cytotoxicity. But if I able to clamp the A and clamp the B together, then it becomes a cytotoxic event and the cell dies. This is called synthetic lethality, when two important pathways are clamped together in such a way that it give up. So when you have a HRD, especially the genes which are involved in the homologous recombination repair, when they are defective, so they are basically already clamped in one arm. Let's assume and give HRR genes as a clamp A. On the other hand, if I use a PARP inhibitor, which is going to clamp the other set of proteins, that is called PARP proteins, which are again involved in the DNA repair, if they are also clamped, it becomes a synthetic lethal scenario. So this is the importance of using the PARP therapy, which is not actually working on the HRR genes directly, but indirectly removing the support system or the backup mechanism of the human cells or the cancer cells to recover from the DNA repair. That mechanism is curtailed, and then it leads to synthetic lethality. That is the cytotoxic effect of these drugs on the tumor cells.
This seems like quite a eureka therapy, I guess. Is it going to really change the lives of ovarian cancer cases?
Yes, it has really changed the life of ovarian cancer patients, and we have seen that the disease-free interval and the overall survival have increased from months to years actually, and patients are very happy. These drugs are relatively less toxic as compared to the chemotherapy what we normally give. So to be honest, yes, we can consider it as a eureka moment for the cancer patients, especially the ovarian cancer.
I just have one more question in the same line. Because it's a eureka therapy, can it not be given to a newly diagnosed ovarian cancer case right away instead of subjecting them to chemotherapy that might give them more side effects?
It's a very interesting question what you have asked. Probably a few clinical trials may address these things in the near future.
Oh,
As of now, the therapy have been used in a maintenance adjuvant setting and a metastatic setting, but not in a new adjuvant setting as of now. But yes, as we see such a beautiful responses, definitely we may see new adjuvant settings very soon, where your thought of removing the chemotherapy altogether and replacing it by a special target therapy may do wonders for the cancer patients. But yet the future has to show all these things.
so we actually, can you explain us about what are the different types of tests that are available in the market currently that can ascertain whether a patient should take the therapy or not, PARP inhibitor
So,
therapy?
couple of options we have for our patients to assess the homologous recombination deficiency, and they can be done on two important aspects. One is on the blood. We can do a germline test to assess important genes which are involved in the HRR pathway. HRR stands for homologous recombination repair pathway, and the important gene is BRCA1 and BRCA2. There are certain other genes which are also involved in this particular pathway, like ATM, PALB2, RAD51. There are other important genes which are also implicated in a similar fashion, can be tested on the blood itself. And we call it as germline alteration testing.
Okay.
This is available in India as well. We have a set of tests, what we call as somatic testing. Somatic testing can be done on the tumor, and somatic testing can also be done on the blood, what we call as liquid biopsy.
Okay.
So somatic test is offered by various companies nationally as well as internationally, which sometimes give you the information on these particular genes which I just mentioned. And this analysis is called somatic analysis. If you see these alterations or impairment in these genes, we can suspect that the patient is having HRD deficiency, that is HR deficiency, and is eligible for PARP therapy. That is one. In terms of liquid biopsy, we can still assess the patient's somatic alterations in the liquid biopsy, and a couple of companies do offer these tests as of now.
Okay, so you mentioned about a lot of tests, like I understand. Does all the tests give a outcome that is yes, no, or it's a variety of outcomes that only a specialist like you can decipher?
So it's a very interesting question, and it is not that easy in upfront. So I will be diving a little bit in deep. So the category, what we are talking about, HRD, there is a category called HRP, that is a homologous recombination proficient. But the HRD category is not, it's a continuous thing. It is not a yes or no.
Okay.
So because the humans or the repair mechanism have a lot of backup mechanisms, even if genes are altered, you may have other backup mechanism which is going to come into play and rescue the tumor cells. So again, it is not an absolute thing. So let us dive a little bit more. If a patient encounters alterations in BRCA1 and BRCA2 genes, the HRD is more strong as compared to the alterations or impairment in other genes like ATM, PALB2. So these two differences are possible. Second scenario is called somatic alterations. In somatic alterations, there is a lot of heterogeneity in the tumor itself.
Hmm.
It is a possibility that not all cancer cells will have this alteration, and the efficiency or the efficacy of the drug will vary depending upon the total number of cells having these alterations, or these alterations, or the dependency of the tumor cells on these alterations. So this is a very important aspect. The third is, to all these causes, the genetic defects leads to a scenario what we call as the HRD phenotype. So understanding the genomic signatures is what we call as HRD genotype.
Okay.
That is the cause, and the consequences of this HRD genotype or alterations is called HRD phenotype, where we can predict the responses to PARP inhibitor therapies or platinum therapies. So this is not a perfect combination. So
Yeah.
there are various variables which can play in,
Okay.
and most of the tests try to address the cause, not the effect.
Okay. All right.
And there are certain tests which include little bit of the cause as well as effect. So there are people who are coming up with a concept of called HRD score, which is talking about the consequences of these causes.
Okay. All right. So either a person can test for the cause, and the better test would be an answer that is cause as well as effect, which is the HRD status or HRD score to be specific. Now we again I'm talking about we are talking about so many tests and a eureka of therapy, but is the test in itself affordable by the by our population?
Um, Affordability is a relative term, but yes, the cost has come down significantly as compared to the past few years. We have seen the technology is improvising or improving very rapidly, and the cost is coming down very rapidly too. And I believe that yes, most of the patients will be able to afford this therapy as the cost of therapy is also coming down. So the test as well as the therapy costs both are going hand in hand, and it is in the favor of the patient who can afford, who can get treated, and who can get better. I think we are in the right direction as of now. Definitely, we expect more to come, cheaper, affordable prices for India. But as of now, yes, it is affordable and reachable to many of our patients as of now.
So, is it right to understand for cancer, ovarian cancer therapy patients or ovarian cancer patients अच्छे दिन आ रहे हैं?
If you talk about, if I say 5 years back, I would have said अच्छे दिन आ रहे हैं, but I can say now अच्छे दिन आ चुके हैं.
अच्छा, that is interesting. So, how is the HRD score measured? Is there a particular cutoff that the patient needs to understand and know?
So HRD score is basically based on a lot of in silico analysis, definitely done on the genomic of the tumor, and it involves majorly three important aspects of what we call as the genomic scarring, which involves the genomic loss of heterozygosity, and another category what we call as loss of telomeric allelic imbalance or telomeric allelic imbalance, large staged transitions. All these are a surrogate way of seeing that what type of genomic instability is there in that particular cancer genome. And once you combine all these things, it gives you a score that is called HRD score. In few studies, the HRD score cutoff was used as number 42
Okay.
for drugs like olaparib and rucaparib. But in certain studies, in recent studies, the cutoff has been reduced to 33 for drugs like veliparib.
Okay.
So these two cutoffs are currently being used in the literature to identify the patients who are eligible for PARP inhibitor therapies.
So, if a patient has a score below 33, he or she is HRD negative and cannot take the therapy. Is that the understanding?
So, as I told you, it is not an absolute phenomena. As these tests are companion diagnostic tests as well as complementary tests to decide whether can we give the therapy or not. But there are other factors which can also take into account, which can help the patient to decide further. But practically, once we see these kind of scores below, the expectations that it is going to work like a charm is not there. And these tests are normally used in the scenarios where we have to use it for the maintenance therapy when when the cancer is not there already. So unnecessarily exposing the patients to PARP therapy, which also comes along with certain side effects, cost to the treatment, all those things, and with not a confidence that it is going to be very helpful, I think cutoff should be respected, and we should not use indiscriminately PARP inhibitor therapy, even if the HRD score is low.
All right. And so, if a HRD score for a ovarian cancer patient is high, there's a chances that he or she may give a better response to the therapy. Yeah.
So higher the number, higher the response, nobody knows about it. But yes, if it is beyond this cutoff limit, we can expect responses.
Yeah. Yeah. So still with HRD in our discussion, we are right now only discussing about ovarian cancer patients, right?
So the answer is this: the HRD score as of now is currently being used for the ovarian cancer, and as well as for the HRR genes are currently being used for prostate cancer.
Okay.
But HRR gene including BRCA1, BRCA2, and ATM is only applicable for breast and pancreatic cancer.
Okay, so a wide variety of tests is available, but right now only a bits and bits of it is applicable currently for few cancer types, and so since the complex nature of these tests, are these tests? I mean, do you advise the patients to take this test on their own, or what should be the process of a patient identifying and understanding and asking the right questions to their therapy treating oncologist? uh, can you guide
So these tests are, as I told you, not easy tests, and it does come with a lot of challenges, especially when you do all these HRR genes, especially the germline genes. There are a lot of implications, ethical implications. If you do this test indiscriminately and a patient is harboring a genetic mutation, then it becomes a lots and lots of obligation of a physician to act on it appropriately to prevent cancers, new cancers, and cancers for the next generation. So it has to be done in a very, very controlled environment where you do a lot of pre-test counseling for the patient, especially the germline test. When it comes to the somatic analysis, pre-test counseling just to explain about the test is acceptable, but there is no need to take a special consent before you do a somatic analysis, as compared to what we do in germline testing. On the other hand, the somatic testing can also pick up the underlying germline alterations. Again, reflex testing is sometimes recommended when you strongly suspect that this patient is harboring germline on a somatic test. So again, just to prevent future cancers in the next generation. The whole idea is to prevent cancer if possible.
So I understand these tests do have a lot of time that they take to give results, about 4 weeks, 6 weeks, depending if they've been sent in India or outside. So when is the right time in from being diagnosed to what is the right time that a patient should get themselves tested at diagnosis, while treatment, post treatment, and
So very interesting question, and what we recommend is to use these tests upfront at the time of diagnosis itself, so that you can plan your therapy accordingly. As most of these tests do not change over time. So whatever alterations you have to begin with remains even during the course of treatment and even later in the later lines of the treatment as well. So it does not change. So earlier the merrier. You can really help the patient to decide what is the next course of treatment for him or her.
okay. So, in our discussion till now, we've understood there is a chemotherapy, and then there's targeted therapy, and targeted therapy is also given as a maintenance therapy. So, PARP inhibitor is also a targeted therapy. Can you explain more about what we mean when we say targeted therapy, and how is it different from chemotherapy, and why is it considered better?
So target therapies is a form of treatment what we give to a cancer patient. And target therapy, the word itself is targeted. It is only focusing on certain, primarily focusing on the cancer cells. So we chemotherapy in general, any multiplying cells is affected, and we know that the cancer cells multiply faster as compared to the other normal cells of the body, and that is why you see a lot of outcomes or treatment responses when you use chemotherapy. On the other hand, target therapies are meant to act only on the cancer cells. The cancer cells and the normal cells sometimes have different features, what we call as antigen or any epitopes or any other special characteristics which we try to harness to go against them. And that target therapies are very helpful. Though it is circulated in the whole body, but does not have any major implications on the normal cells. So that is the benefit of target therapy. In this particular example, what we are talking about today is the PARP inhibitor therapy, which goes and bind the PARP. There is a PARP is a protein which is sitting in the cells, which is practically sitting in all the cells.
Okay.
But primarily, as it is, as the tumor cells are multiplying faster, and this PARP therapy is going to go and attack all the PARP in the body, but tumor cells being are affected more because the genomic instability is one of the key things which is underlying the cancer cells.
Hmm.
So the cells which have high genomic instability because of the HR deficiency, they are lethal when we use PARP inhibitor.
Okay.
So it is considered to be a target therapy. In terms of the side effect, as I just mentioned, it is focusing on the cancer cells, not on the whole parts or the other parts of the body. You see very less side effects. Certainly, any multiplying cells who expresses PARP may have implications, but not that high what we see in the chemotherapy.
Okay, all right. And are these drugs once suggested by your oncologist available in India and available off the shelf?
So these drugs are now available in India, which have been approved by the US, the Indian FDA, and on prescription, the patient can buy from pharmacy, which are special pharmacies which carry all these important drugs. But yes, two of the drugs which are available in India as of now, that is olaparib and rucaparib.
Okay, and are these drugs injected through IV line or are, like proper medicine kind of drugs?
So luckily, it is very good for the patient. It is these are oral drugs. Easily, they can take this tablets or capsules, which can be taken twice in a day, and that's it. Very simple to and with lot of good compliance. What we have heard that patients take all these things in a regular fashion.
All right. So generally, my understanding is that depending on the type or depending on the patient specifically, the dose is suggested. Like how long should they have medicines? But in general, these targeted therapies go for how long? How many more months uh, at a
In terms
stretch?
of the dosage,
Yeah.
all the drugs have their different dosage schedule. It is given in a continuous form. It is never stopped. In the terms that is given continuously on a daily basis. How long we should continue depending upon whether it is a treatment or maintenance. For maintenance purposes, approximately 2 years is what we normally follow.
Continuous 2 years.
Continuous 2 years. For treatment, if we get a response and if the patient can tolerate the drug better, until the next progression, we continue the drug. So these drugs are well tolerable. Timing depends upon the patient's either affordability, toxicity of the drug itself. But as I said, 2 years for the maintenance and in treatment till progression.
All right. This is quite. I mean, this is nice to know. I mean, I thought it's like chemotherapy that a 3 month drug time. I mean, 3 months of chemotherapy time and then it's done. But targeted therapy usually goes for a longer time. And along with this targeted therapy, say PARP inhibitor, are there other drugs that are suggested?
So this is given in a form what we call as monotherapy, single drug. We do not combine these drugs in routine practice, uh, and that's about it. There is a scenario where we combine this drug with another targeted agent.
Okay.
In a trial called Paula trial, what we have seen, patients with ovarian cancer benefited when combined with olaparib with bevacizumab. So sometimes we do combine, but they can also be given in monotherapy form.
So I just wanted to also understand when people take this PARP therapy, does it fail at some point? Or it's a continuous eureka moment once the patient has a higher HRD score?
So we understand cancer is smarter than us.
It truly is.
And
Yeah.
when we start giving this kind of therapy, cancer cells also evolve. They initially respond beautifully to all these important target therapies. But what happens that they come up with some mechanisms to circumvent these actions. One of the important mechanism is that called efflux mechanism. When you give this drug, it goes inside the tumor cell, and the tumor cell pumps it out by using special pumps that is called efflux pumps.
Okay.
And then the drug is not available to act. That is one of the mechanisms. Sometimes the HRD, depending upon is dependent on a particular mutation sitting in the BRCA genes. Sometimes these genes mutations reverse to become normal. This is called BRCA mutation reversion. And there are certain other proteins which are involved in the repair either become overactive and causes resistance to the PARP therapy. Sometimes PARP overexpression in itself can cause PARP resistance. There are various mechanisms which can cause all this resistance to happen, and it is difficult to predict when it's going to happen.
Okay.
So duration of responses cannot be predicted as of now, but we have seen that sometimes if you give a drug holiday, sometimes the cancer reverts back to its original form and start responding to the PARP therapies. So this is a very unique
Drug
scenario.
holiday is a new term I've heard for the first time.
So
but
drug
yeah.
holiday is normally given for scenarios when we have to give treatment for longer period of time,
Okay.
and the acclimatization of the tumor cells to these drugs is the reason why they don't work. So if you give them drug holiday, they think that now they can relax, and then they again become susceptible to these drugs.
So, like in reality, there are bumps to Achhe Din also. So, it's not that if one is taking the monotherapy or targeted therapy for 2 months or 2 years long, that it's end of the story. They still have to continuously keep referring to their doctors and keep also making sure if the therapy that is being given is effective or not.
So as I said that these therapies are not long lasting. It is though it is you can say relatively better than the chemotherapy, but it cannot guarantee a complete you can say cure of the disease, especially in the metastatic setting. Definitely to touch base with the doctor for the possible side effects. There are some immediate side effects, what we
Okay.
call as acute side effects. There are some chronic side effects. Very rare side effects do happen, have been reported, like leukemias, like MDS and AML, have been reported in the use of PARP inhibitor therapies. So again, in be in touch with the doctor is a must. Sometimes the doctor can do some titration of the dosage, can give you some dose which is better tolerable
Okay.
tolerable to the patient and equally still effective actually.
Okay.
So it's better to be in touch with the doctor while on the therapy.
So, have you have had a patient who's under your purview treated in with PARP inhibitor, and can you share her experience through the journey of this targeted therapy?
Yeah, so we have treated a couple of patients. Uh, and we had good success so far. And based on the information what we get on the germline testing or the somatic testing, we have used these PARP therapies, and it have worked like a charm. So just if I am able to recall one of my patients who an ovarian cancer patient who failed multiple lines of chemotherapy, and it was the time when we did not have this drug or the guidelines that easily available. We used this therapy almost 7 years back, and the patient is right now disease free. So sometimes the wonder happens, and the patient was harboring a germline BRCA mutation. So that was my first patient when this drug was recently launched,
Okay.
which I could remember. This is the best success story what I have. But there are other success stories where we have used these drugs in scenarios where the clients have failed and the HRR genes are defective beyond BRCA1, BRCA2, and they have shown good results. where the expectation was very low, but still they have worked like a charm. So I have various examples, but right now I would like to restrict my discussions to few of them. But so far so good. We have also seen progression on PARP inhibitors, which I can recall a case which has progressed on PARP
Okay.
inhibitors post treatment 5 years actually. So, but it gives good duration of response. Failure is also inevitable, but luckily the patient is responding to other forms of chemotherapy.
Okay. So, this conversation with you, Dr. Verma, has been very interesting because um, there are these peaks and moments of realization in this conversation. You like at once you feel you found the eureka, but all of it is not easy and clear. At one point, you feel the therapy is one for all and maybe just cure the patient for good, but no, that may also not be true in all the cases. So yeah, the I think the message that I take is uh, newer therapies and newer treatments are coming up, and so one needs to open up and keep the information. The oncologists as well as the patients need to be aware about what are the new therapies and treatment options and diagnostic tests in the market. See if it is applicable in their case. But at this point yet, nothing is going to change the entire course of treatment. Everything will be still one step at a time or one day at a time. But as compared to a few years back, there are a lot of promises that these newer targeted therapies are giving to patients' lives. Right?
Certainly, it's a new promise. It's a big promise also, and the patient should discuss all the options with the physician, the treating physician, when to apply all these information, the test and the drugs, the side effects, the long duration of responses, the benefits, and certainly patients who have HRR genes should also ask the physicians that is it in their genes, and are they going to pass it on to their next generation? It's a very important question which they also have to discuss it out with their treating physicians.
Okay. Okay. So, when I introduced you at the beginning of the session, uh, you have some very interesting accolades and designations that are new to hear. So, I just wanted to understand, as a molecular oncologist, when should a patient, if they wish to, come and uh, consult you? In what course of their treatment and why?
So now the paradigm is changing. The conventional or the blanket treatment is changing into precision oncology. And as I practice precision oncology primarily, I normally recommend the patients to come upfront. Upfront information sometimes is very helpful because the tumor is treatment naive and responds to some target therapies better as compared to in the later lines.
Okay.
As the tumor learns, it becomes trickier and trickier for us to handle. It becomes more and more complex during the little course of treatment. So early on is what I recommend. If patient wants to know more about the tumor biology, they are most welcome to discuss the case with us. If they want to know more options beyond chemotherapy, again they are most welcome to discuss. In the scenarios when they fail the conventional treatment, certainly molecular oncology comes very handy to find new options. They may not be in the books, they may not be in the guidelines, but sometimes give a lot of hopes to the patient that this is the way forward.
Yes. So, can you help us summarize about homologous recombinant deficiency test uh, in a clear summary?
So, to summarize today's discussion, the take home message would be patients, primarily ovarian cancer patient, prostate cancer patients, breast cancer patients, and the pancreatic cancer
Yeah.
patients should undergo the gene test, what we call as HRD test. Depending upon the need or the guidelines, the doctor may recommend a germline HRD test or a somatic test
Okay.
or both of them. And based on that test and the results, if it is suggesting that the tumor are HRD, not HRP, that is not HRP. If it is HRD, then the doctor will recommend the PARP inhibitor therapy, which may be given in a form of a tablet for long duration as a maintenance, or can be given at the time of recurrence, that is called treatment. And that's it for
Yeah.
yeah.
So, just on a lighter note to conclude, like in COVID testing, being positive was not good. I think in terms of ovarian cancer, we want to be HR deficient and not HR proficient to benefit from PARP inhibitor therapy. Is that correct?
Yes, HR deficiency is considered to be better because we have drug available now.
Okay. Yeah, so I think the paradigm for the outcomes of the tests and how what it means for the patient is continuously changing. So positive and negative is not always by the word that it means in the diagnostic test. So thank you so much, Dr. Verma. This has been a really enlightening session, and like I said, a kind of a rollercoaster ride, because every time there is something that is creating hope, there is also something reality that is balancing the way forward. But I think this conversation has cleared a lot of understanding for me personally, and I would really suggest all the viewers to keep hearing our episodes that will keep linking the topics that are discussed today, and going into the depth of a few concepts of precision oncology, so that all of you understand the therapy that you've been suggested, the molecular therapy that you've been suggested, advised, and why not. Thank you so much.